This recorded review will be going over the Foundations 2 Exam 4 study outline over chapters 33 through 36. So we will begin with drugs that should never be crushed. On page 653 within the bolded text, you can see that sublingual, buccal, enteric-coated, and extended-release products and products with carcinogenic material or potential should not be crushed. When a liquid form of the drug is available, a more exact dosage can be achieved than with a crushed pill. A liquid dose can also be more time efficient for the nurse. One of our concerns with crushed drugs is that they could potentially lead to indigestion with the patient, and it also will affect the way that the drug is absorbed and the way that it will affect the patient, potentially interfering with its therapeutic intention and effect. How to administer an intradermal injection. So for that, we're going to flip to chapter 35. And for this one, it discusses the intradermal route on page 689. So you can read that small little box there. Also, what you want to focus on for this one is the actual skill, which you can see on page 698 through 700. So understanding the technique to administer an intradermal injection is going to be important. This is going to include the needle size that you would like to use, the angle that you are going to insert the needle on the patient's skin, and any other considerations as well that would be listed under the evaluation, documentation, and implementation section of that skill. So for how to prevent needle stick injuries, on page 692, there's a red box with the safety alert about reducing needle stick injuries. Recapping is never recommended for used needles. All syringes and needles should be dropped, not pushed, into a sharps container immediately after use. If the sharps container is not available in every patient's room, notify your nurse manager. So you would leave the needle uncapped and you would drop it in a sharps container. How to administer otic medications. So we're going to flip back to chapter 34 for this one. And again, for this, you're really just going to focus on the skill. And we want to be paying attention to the adult and the pediatric guidelines. Now, the skill for this one you can see is on page 675. And then there's additional information about otic medications on page 673. And you can see on page 673, it says for the child younger than 3 years, pull the earlobe downward to straighten the canal. And in the adult, you pull the top of the pinna out and upward. And then this is repeated again in step 3 on the skill, instilling otic medication on page 675. So for that, you really just want to pay attention to how you are going to give it. So the steps and the skill. And then again, the differences between how you would administer an otic medication for a pediatric patient and how you would do so for an adult. How to apply a transdermal patch to a patient. So for this one, you can see kind of an introduction to the topical drugs on page 666, but then you can see more in-depth information about transdermal specifically application on page 680. So reading that section there at the bottom of the skill on page 680 is important, and I would also again pay attention to the safety alert on that page. I would just, as a general recommendation, pay attention to the safety alerts on all of the pages throughout chapters 33 through 36. Safety when administering IM injections. So for this, we're going to turn to chapter 35. And again, you can see a little bit about the intramuscular route on page 689. I would also again pay attention to that purple clinical cues box at the bottom of 689, which again is referring to different sites that we can use for the IM route. as well as how much medication you can put into a specific site. Specifically, the ventrogluteal site, you can use up to 3 mLs to be safely injected within the ventrogluteal, vastus lateralis, and rectus femoris sites in most of our adult patients. Then as far as the IM injection, again, with this one, we want to pay attention to the specific technique that you are using, which is going to be found. The skill starts on page 705 and it goes to 707. There's some additional information on page 704 about intramuscular injections, which can be important to pay attention to. I would pay attention to the bolded text in that area. On page 704 to 705, and then additionally pay attention to the steps of the skill on 705 to 707. So you really want to pay attention to the implementation, and then of course any special considerations on page 707 would also be helpful as well. On page 705 as well, you kind of want to know how to locate a couple of these different sites. One of the most common sites that we use with our IM injection is going to be the deltoid site. So on page 705, it does discuss how you would locate the deltoid site. That would be important to pay attention to as well. Using the Z-track technique, so the Z-track technique is discussed on page 709 at the bottom there, and it says that nurses are encouraged to use the Z-track technique anytime that an IM injection is given. This is done to prevent any leakage and associated pain. It absolutely must be used whenever a deep IM injection is given, especially of iron dextran or another type of irritating solution like hydroxyzine hydrochloride, as well as several antipsychotic agents. Always check your drug insert that comes with the medication, and then that can give you additional information on how you should do that. Then the steps for using the Z-track injection are going to be on page 710, and again, I would take a look over that as well. On page 710 also, I would pay attention to that safety alert at the bottom of the page, watching for allergic reactions. This discusses why it's so important for us to wait for the patient to be observed for about 30 minutes after we give them an injection. So again, that one is going to be very important on that page, 710. We discussed how to locate the deltoid muscle, how to administer a sublingual medication. So back in chapter 34 on page 672, you can see sublingual is a key term. And on page 672, that sentence is important. So sublingual medications are placed under the tongue. They should never be swallowed. The drug dissolves in the sublingual pocket and will be quickly absorbed by the vessels in the oral mucosa. Another thing that I would like for you to pay attention to is on page 668. The bolded text on page 668 regarding recording the water with medication administration on your intake and output flow sheet is very important. And then on page 669, pay attention to that older adult considerations box regarding difficulty swallowing pills and then the strategy you would use to help that patient swallow their pill. How to withdraw medication from an ampule. So for that one, we're going to go back to chapter 35. And for this one, you want to pay attention specifically to the skill again, which is on I would take a look at the clinical cues on page 693. Before breaking open the ampule, you want to wrap the neck with a rubber ampule guard, an alcohol swab, or gauze pad to avoid any accidental cuts. You want to press your thumbs outward against the neck so that the ampule breaks outward away from you. And it's important to note that we always want to use a filter needle to actually withdraw the medication from the ampule. However, the filter needle is never ever going to be used on the actual patient. And then the steps for withdrawing medication from an ampule are going to be on 694. So I would pay attention to that as well. Steps for administering a subcutaneous medication are going to be on page 700 through 702. Now for this one specifically, what you want to pay attention to is on page 701, the implementation steps, especially how you're going to insert the needle into the skin, the angle that you are going to use. You also want to pay attention to how you're going to document the administration on page 702 and the special considerations that are listed on there as well. Now remember, with our subcutaneous injection sites, we need to be rotating them systematically and consistently as we're providing those medications. On page 702 as well, within figure 35.17, you can see some different subcutaneous injection sites that can be used. And you can also read a little bit more about these different sites within box 35.3, discussing the subcutaneous administration of heparin. The steps to administer ophthalmic medication are going to be back on page in 34, chapter 34, and you're going to see this on page 673 and 674. Now what we want to pay attention to is specifically the eye drop application. You're not going to have any questions on eye ointment application. We're going to go over this when we do the skills, but you want to pay attention to the steps of eye drop application. That's really going to help you for those couple of questions. Appropriate sites for IM injections. So we kind of discussed that already and where you would find those. The sites that you really want to pay attention to are going to be, again, the ventrogluteal site and the deltoid site. And remember to pay attention to that clinical cue that we pointed out. Agonist versus antagonist. So we're going to go back to chapter 33 for this one. And for this one, you really just want to understand what does this mean? What is an agonist and what is an antagonist? And you can see this on page 641. So drugs that produce a response are agonists, and drugs that block a response are antagonists. Now, you also may be given an example of a drug for this type of question. There are two questions based on this concept here, and you will be given examples of drugs, and which are very common drugs that you should have definitely seen and heard of before, especially if you are also practicing in your ATI pharmacology textbook with those questions there. So I would just be familiar with like some very common examples of agonist type drugs and very common examples of antagonist type drugs. And that's going to help you a lot with those couple of questions there. Steps to administering suppository rectal medications. We're going to flip on back to 34 here. And for this one, again, you want to really just pay attention to this skill, which is on page 678. So there's a little bit of information on page 678 within the text, but most of the information that you're going to want to get from this is on the skill. It starts on 678 and it ends on 679. Paying attention to the position that you want to place your patient in, the materials that you are going to need for this type of medication administration is going to be very helpful there. Medication administration safety. We're going back to chapter 33 for this one. Now again, we're paying attention to all of these safety alerts, especially within this chapter. Medication administration and safety starts on page 642. Pay attention to the bolded text in this section as far as additional safety alerts that will be helpful for you. I would pay attention to, as we said, the bolded text on 642 and 643. Pay attention to the safety alert on 643. Paying attention to the safety alert on page 648. It starts on 648 and it goes on to page 649, but it discusses just the planning steps that you need to be using and the 6 rights of medication administration. Well, our 6 rights of medication administration go hand in hand with our medication safety strategies and tips. So I would pay attention on page 650 to the bullet points under implementation. That's going to be super helpful for you there. On page 653, giving the right drug to the right patient, correctly identified using 2 identifiers. That section is going to be very important. I would pay attention to that. On page 654, there are 2 additional clinical cues. Pay attention to those. And on the box 33.3 about performing the 6 rights, that is going to be important as well. So for medication safety, you're going to want to take a look at those. So INO measurements, that was kind of that bolded text that we had already discussed. Whenever you're giving oral medications, we always want to make sure that we are actually recording that intake that we're giving with our oral medications on the intake and output record. We don't want to just ignore that intake. Even though sometimes it can be a small amount, we just want to make sure that we are including that because as we know, our intake and output record can be very important, especially for patients who are on potentially a fluid restriction or who have kidneys that are not working appropriately. When to change a continuous IV solution bag. So we're going to get on into chapter 36 now. So on page 734, where it discusses the skill hanging a new solution using an existing IV infusion setup, it actually says it right at the beginning of that skill. When an IV is to remain in place, another bag of solution must be hung before the last bag runs dry. This new solution or new bag should be hung when the old bag reaches approximately 50 mLs. So your IV bag should be changed when about 50 ml remains in your existing bag. A synergistic effect, we're going to go back to 33 and you're going to look on page 642. It's actually a key term. So a drug interaction could result in an increase or a decrease in the action of another drug, or it could alter the way in which a drug is absorbed, metabolized, or eliminated from the body. A synergistic effect, which means a combined interaction of 2 drugs, will occur when the action of 2 drugs is combined or increased greater than the effect of the drugs when given separately. For example, alcohol has a synergistic effect when it is combined with any drug that depresses the CNS because it is also a CNS depressant. So understanding that concept of the synergistic effect, being able to identify it if an example was given to you, and then also remembering that example of the alcohol with CNS depressant drugs. Monitoring for an allergic reaction, so we already kind of discussed that. That was in that safety alert that I had pointed out earlier, why it's so important to monitor our patients for about 30 minutes after we give them a medication. We're monitoring for an allergic reaction. Blood transfusion reaction signs and symptoms. So we're going to go back to 36 for that. And you're going to see it on You're going to see this on page 743. It's going to be under the administering blood and blood products. Again, paying attention to our bolded text here. So observe closely for any transfusion reactions. Reactions to blood transfusion will typically occur very shortly after the beginning of the infusion has been started, within about 5 to 15 minutes. These reactions will be most common whenever packed red blood cells or whole blood is administered. Signs of a potential reaction could include hives, itching, facial flushing, chills, back pain, apprehension, and fever. If a reaction to the blood occurs, the blood should be instantly shut off. Begin normal saline with fresh tubing, keeping the IV access open in case any emergency drugs are needed, and immediately afterwards notify your primary care provider. So the steps on that are pretty clear on how that should be happening. Shut it off, start your normal saline with fresh tubing, notify the doctor. Then we're going to notify the blood bank, and we're going to take additional steps, and including, of course, documentation. Steps for mixing insulin. Going back to chapter 35 here. Excuse me. And you're going to be looking at the skills specifically for mixing insulin. It's on page 696. So what you want to pay attention to here are the actual steps on combining insulin skills. So it's important to note that when we're combining insulin, how are you going to do that? Are you going to use the clear insulin first, or are you going to use the cloudy insulin first? Where are you going to put your needle into the vial? So those are going to be important things that you want to pay attention to with that skill specifically. How often should an infusion pump be checked? So we're going to go back to where we were in chapter 36. And you are going to look on page You're going to look on page 734 where it says keeping the IV solution running. So a primary responsibility is to check the IV at least every 60 minutes and to observe the following points. Your eyes should travel from the IV bag down the tubing and to the actual catheter site. We want to pay attention to the IV flow, the rate of the infusion pump, the insertion site. Explore any potential patient complaints and always notice how much fluid you have left in your bag. So it says about every 60 minutes, so we want to do this about every 1 to 2 hours. You should be checking not only the IV pump, but also your IV solution every 1 to 2 hours. Therapeutic drug level. So this is just kind of understanding what this concept means. Like what is a therapeutic drug level? Now we can see this back in chapter 33. You can see this on page on page 641. So on page 641, we discuss that the length of the time a drug exerts a pharmacologic effect is its duration of action. Now it talks about different key terms on this page. We're discussing what a peak action is, what is a half-life, what is a peak, a TRO, and what are the levels for certain drugs to ensure an effective concentration level. Now right under that, you have a small paragraph that says, when giving sequential doses of a drug, it is important to time the doses so that a drug's concentration in the blood never drops below the minimum effective level. However, if doses of a drug are given too closely together, the peak could be exceeded, causing a toxic concentration of the drug in the body. So that therapeutic drug level is that minimum effective level that we want to kind of obtain. We want to make sure that the drug never goes below that minimum effective level, because at the minimum effective level, it is therapeutic within the body. So just understanding that concept on page 641. Best practice for choosing IV sites. Heading back to 36 here. So on page 728, there's a section that says selection of the IV, the intravenous site. So notice how it says that the veins preferred for infusion and intermittent doses of medications will be those distal to the antecubital area. A new site cannot be placed distal to an old site. So this is one of the reasons why we say that you should start low and work up the arm, because, for example, if I put the IV in my antecubital site and that antecubital site ends up blowing, or it gets an infection, or it starts leaking, or for whatever reason, some type of issue, I can no longer use my antecubital site. Well, the only way I can go is up, right? I'm not supposed to be working proximal to that site. You have to go distal. The new site cannot be placed distal to the old site, so I wouldn't be able to place it farther away. Remember, when we talk about these terms, proximal and distal, that we're referring to the midline of our body. So if I was to go distal, then that it would be not appropriate. For example, if my AC site blew and I decided to potentially use a forearm, you really shouldn't be doing that. You kind of want to work up the arm at that point. So then the only place I have to go if my AC blows is up into my upper arm. And that's somewhere that we, don't really like to go too much because the veins are very deep. So that's why we say start low and work up the arm. So that's going to be an important concept to understand what our best practice is when you're choosing your IV sites. Now, regarding phlebitis, this is on page 725, and you want to pay attention to that entire, it's a very small little not even chapter, paragraph there. Phlebitis is caused by irritation of the vein by the needle, catheter, medications, or any additives in the IV solution. Typical signs of phlebitis include erythema, warmth, swelling, and tenderness. The IV must be discontinued and another site must be found to reinitiate the IV therapy. The application of warm compresses to the inflamed site can decrease comfort. So that is important there on page 725. Helping a patient swallow pills. So I kind of pointed out that was in the older adults consideration box back when we were discussing the oral medication. So that's going to be helpful for that bullet point there. Now, safety measures with medications that lower blood pressure. Now for that, we want to go back to page So for that one, we want to look on page 644 and 645. These are our considerations for the older adult. Now on page 645 specifically, it says that some older adults will be more likely to have greater blood pressure fluctuations with position changes. Therefore, they can be more susceptible to falls when taking drugs that could lead to orthostatic hypotension. So that would be a very, very important safety measure to consider with our older adult population, as well as whenever giving any type of medication that will lower the blood pressure to a patient. Medication history. Now, this one specifically is referring to some of the bullet points that we can see on page 650. So when we're giving a patient a medication, we always want to understand why. Why are you giving that patient the medication? You should never be administering a medication without understanding what the medication is and does, what the potential side effects and severe complications are, what points of patient education you want to give to that patient, most of the time side effects, as you're administering them. And of course, why is the patient getting this medication? I want to know why they are on it so that I can better understand and more accurately administer this medication so that I can understand better about my patients and be able to use my critical and clinical judgment to my best degree. So on page 650, it says, obtain a complete medication history from the patient. Look for any potential drug interactions among the medications the patient is taking. Now, by looking at the medical history, we can help determine that why before we administer a medication to a patient. Now, this could be a new medication that we hadn't seen before, or it could be a patient that is new to us, and we're trying to understand, why am I giving this patient this medication? That is one of the key things that you should always know about a medication prior to giving it to your patient. Now, discussing the narcotic count, we can see some information about this on page 638. It's going to be under the legal control of drugs. And again, you want to pay attention to the bolded text in this section. So in a majority of hospitals, Schedule 2 and 3 drugs will be dispensed in limited amounts to nursing units. They will then be stored in a locked narcotics drawer, compartment, or automated dispensing unit. The licensed nurse will be responsible for the security of these medications, and therefore they must account for each dose that is used. That's why we count them when we take them out of the drawer. A record will be kept on the nurse's notes that each dose is given, to whom, and when. A proof of use record will account for each dose that is dispensed to the nursing unit. When the contents of the locked narcotics drawer are counted at change of shift, there should be a record of each of the doses given, a dose of the drug remaining for each unrecorded line, and the total remaining. The automated dispensing units will track these doses removed by each nurse and the computer, and then an end of shift printout can be used to be printout can be run and used to identify any potential discrepancies. So an important thing with this is that the narcotic count essentially needs to be done with 2 nurses, and you do this at the end of shift. So you're going to be doing this with a nurse who's coming on to shift and a nurse who is leaving the shift. So decreasing comfort during parenteral injections, we can read a little bit more about this on page 688, where you can see the principles of parenteral injections. So I would pay attention to the reason that we're giving them. So these injections are given for the following purposes, and then the bullet points underneath there. Again, I would pay attention to the bolded text on that page on 688, as well as within box 35.1. Principles for safe, effective administration of parenteral medications. How to set up for a blood transfusion. So essentially with how to set up for a blood transfusion, this is going to take us back to chapter 36. And again, you want to look at this skill on page... The skill starts on 744 and goes to 746. So under administering blood products on 743, it talks about how normal saline should be the only solution used in conjunction with a blood transfusion, as well as that the patient must sign a consent form to receive the blood, and the consent form should be no older than 48 to 72 hours prior to the transfusion initiation. So those are some important considerations to remember with our blood transfusion administration. Now, with how to administer piggyback infusions and medications, we can see this on, the skill is on page 738 to 739, and then they also discuss piggyback medications on 718 and 719. So on 719, the bolded text under secondary or piggyback intravenous set is going to be important. Understanding how the piggyback medication is going to be hung in relation to your primary bag. So the secondary bag containing the medication, known as the piggyback, must be hung higher than the level of fluid in the primary IV. This is so gravity will force it to empty first. It's important to not clamp or alter the flow of the primary bag. If the secondary bag is positioned correctly, the primary IV should begin to flow as soon as your secondary bag is finished. And then just understanding the steps of how you would administer a piggyback infusion on page 738 to 739. Trade name versus generic name. Going back to 33 here. You can see this on 636. So although drugs could have 3 potential names, a chemical name, a generic name, the generic name is the name that is not protected by a trademark, and a trade name. The trade name is the name that is protected by a trademark. Knowing the generic and trade names typically is sufficient for the nurse. So understanding what is the difference between a generic name and a trade name. Infiltration. taking us back to 36 on page 724. So just reading that section there at the bottom of the page on 724 on infiltration, understanding why infiltration occurs, what the signs and symptoms would be, and if it occurs, what are you going to do about it? That's going to be the biggest things you want to understand for infiltration. The proper handling of a syringe. We can see this on page 690. So on page 690, you can see in figure 35.3, you can actually see the parts of the syringe. It's important to note on that figure 35.3 the parts that need to be kept sterile and the parts that need to be you need to avoid touching. And again, on page 690, the bolded text under types of syringes is going to be super helpful for you for that question. That's going to help you understand how you should properly handle a syringe. How many times should a nurse attempt an IV insertion before they call for help? Now with this one, we're going to actually see this within the skill in chapter 36, which is on page... it is on page 7. The skill starts on 728 and it goes to 732. So under the special considerations on page 731, that's where you are going to find this information. If you cannot initiate a patient IV in 2 attempts, you must ask another nurse to perform the task. So 2 strikes and you're out. You should never be trying more than 2 times to get a peripheral IV site successfully. Reconstituting medications, that one kind of goes hand in hand with that combining insulin. So again, just understanding how you're going to do that. When you're withdrawing medication from a vial, you want to understand where you're going to place the needle in that vial. You can see that on page 695 within that skill. So just understanding where you want to put the needle into the vial and understanding the steps for page 695 for withdrawing medication from a vial. And choosing an insulin site for injection, we kind of talked about that one as well. Very important to make sure that we are rotating the sites. And then again on page 702, you can see the different subcutaneous sites that could potentially be used, and you can read a little bit more about those sites within box 35.3 under the subcutaneous administration of heparin. So before we end here, I'm just going to take us back to chapter 33 and kind of go through really quickly anything that I may want to touch on a little bit more. So one of the things that we want to pay attention to as well on the bullet points on page 651, notice on how the last bullet point there, it says including any patient education that was done about the medication, the dosage schedule, or precautions. Patient education of side effects and what the medication is, why they're getting it. It's an important thing that we want to talk to our patients about as we're administering medications. So we want to make sure that in all of the safety checks and everything that we're doing, that we're not forgetting about educating our patients, and then of course documenting that education, because we want to take credit for that good work that we had just done, right? So that's it for 34, including everything we already went over. Or I'm sorry, 33. Looking over chapter 34 now. So on page 666, it also has additional information about that narcotic count, which we kind of already covered, but it says regardless of whether the drugs are counted manually or by a computer, each dose of a controlled substance must be accounted for and the number remaining verified at the time of shift change. This will be done by one nurse from the oncoming shift and one nurse from the shift going off duty. They will count together. Any discrepancy must be resolved at that time before the nurses on the ending shift have left the unit. On page 666 as well, pay attention to that lifespan considerations box with the older adults regarding potentially dropping a pill into dirty linens and what you would do about that. When it comes to on page 672 with administering oral medications, that skill, I would just pay attention to the special considerations on page 672. Those bullet points there, that can be very helpful. Once again, it does talk about the intake and output record regarding oral medications. It also talks about the assessment of the swallowing reflex that we would like to do prior to giving an oral medication. On 673, when we're talking about that eye medication again, making sure that we are dropping the eye medication into the lower conjunctival sac and that we're holding the eye drop solution at least 2 centimeters above the lower conjunctival sac. It should never be touching any part of the eye. Otherwise, it must be considered contaminated and thrown away, even if you're using it on the same patient over and over again, because potentially any bacteria from the eye could then get onto the bottle, into the medication, and contaminate it, potentially spreading further infection. And that's about it for 34. Moving on to 35. So on page 689, like we were discussing, pay attention to that purple clinical cues box. Also pay attention to the fact that aspiration is not currently evidence-based anymore. That's why we do not currently recommend aspirating with intramuscular injections. One of the things to understand too is that when you're giving an intramuscular injection, some of them use a passive needle safety device. What that means is that the needle will retract back into the syringe barrel after you have administered the medication. You usually have to press a little button or you kind of apply pressure to a part of the syringe, and then the needle will retract itself for safety reasons. On page 700, for reading a tuberculin skin test, we want to understand that we read the result between 48 to 72 hours after injection. A tuberculin skin test is typically 0.1 mLs that are administered on the left inner forearm, and then you want to instruct the patient to return within 48 to 72 hours. Another important consideration with our intradermal injections is that you do not want to massage the site after the intradermal injection. Reason being is because we are typically inserting a bleb at that point. And why would we massage the bleb back into the skin? You know, you want to inject the bleb slowly and then leave the bleb there in order to kind of manifest and potentially give us any, potential result of induration a couple days later. There are some additional ways to decrease injection and comfort within box 35.4 on page 708. I know we were kind of talking about how to decrease discomfort with parenteral injections. That box is going to be helpful for you there, making sure to pay attention to the appropriate needle size. And that's about it for chapter 35. And then for chapter 36, and chapter 36, we basically discussed everything that needed to be discussed with that. So that is about it for this review of this study outline. There is one select all and apply question on this assessment, and I wish you the best of luck. Happy studying.